You are now listening to MedEd Talks Primary Care, a Vindico Medical Education production. The following podcast series is titled Expert Weigh-In Podcast Series. To earn CME credit, log into mededtalks.com and search Expert Weigh-In, or click the link in the notes section of this podcast to go directly to the activity, take the test, and complete the evaluation. Before beginning this activity, please be sure to review the faculty and the learning objectives. Now, here's your host, Dr. Robert Kushner.
Hello, I'm Robert Kushner, professor in the departments of medicine, medical education, and former director of the Center for Lifestyle Medicine at Northwestern University Feinberg School of Medicine in Chicago, Illinois. I'll be your host for this exciting new podcast series titled Expert Weigh-In. In these podcasts, I'll be interviewing physician experts on various topics in obesity management. In this episode, addressing dilemmas in the new era of obesity medications, I'll be speaking to Dr. Jamie Ard. Dr. Ard is a professor in the Department of Epidemiology and Prevention at Wake Forest University School of Medicine in Winston-Salem, North Carolina, and immediate past president of the Obesity Society. In addition, he's a good friend and colleague. Welcome, Dr. Ard.
Thanks, Bob. Glad to be here.
Wonderful. It's so great to have you. And I think you're just perfect for this podcast because of the way you operate and think and your publications. So, Jamie, I want to start, we are both aware of the explosion of the highly effective obesity meds. It's semaglutide and tirzepatide. And they really have changed the landscape regarding how clinicians and patients think about obesity. That is, as a chronic progressive disease versus personal character fault. Do you think that's true? Do you think it is changing the perception of how we and patients think about obesity?
Yeah, I do think this is true, Bob. And I think it's true for a few different reasons, some of which are directly related to the medications themselves and the experience that patients have with seeing things like turning down what colloquially people are calling food noise. All right. So having a way to describe the biologic effect, right, in a term that gets into the popular vernacular. So I think that's one aspect of it. And it starts to sort of help people recognize like, oh, there's something there. There's a there, right? And it's not just people now all of a sudden have more willpower. I think the second thing that's really kind of a cultural phenomenon is just the visibility, the popularity, and the number of conversations that are being facilitated by people who are, like yourself, very famous, like Oprah and others, right? Who, now have started to bring these discussions into the fore, and they're tying that with, oh, this is what the medication is doing. This is how it's impacting me. It's a personal story, a narrative. And you're starting to see also the integration of medical expertise in those conversations that helps to explain the biology. And so it's a very different sort of perspective than the tabloid pictures that, you see in the grocery store, which is basically what we have lived through for a lot of our career, where it's sort of the miracle cure, blah, blah, blah. And it's a fanciful story, but doesn't really, sort of connect to the biology and the, actual, medical perspective.
Yeah, I agree. I think it has changed the entire landscape of how we talk to patients. For years we would like try to bring up medication and they say, I don't need it. It's my fault. I know what to do. Boy, this accelerated the conversations in our office. And they really, I think our understanding these medications have a real role in managing their weight. There's another dilemma regarding the use of these medications, and in fact, there's many, but let's start by talking about the primary care workforce that's needed to prescribe and monitor these medications. According to some publications I'm aware of, about 3 to 5% of patients who are eligible for these medications actually are being treated with them. So the question I have for you is, how do we address this challenge of getting the medications in the arms or the mouths of those who need it? Is the primary workforce sufficient enough, educated enough to actually follow through and treat the patients with these medications?
Yeah, I think the answer to that simply is no. We don't have the workforce to meet the demand when, by BMI standards, you would say, 40% of people in the country are potentially eligible for treatment. Um, Certainly, even if you said, okay, clinically, we think half of those individuals should be actually treated with meds. There's no disease state other than hypertension that I can think of that you're talking about 20% or more people who you want to try to get access to treatment in a comprehensive way that is meaningful, that will allow for sustained treatment with minimal adverse events. And we're also really focused on the highly effective medications, but not everyone has access to those. And being able to have some knowledge fluidity of the older medication, earlier generation medications is also a part of this, right? So if you don't know how to prescribe one of the newer meds, then and you've not been prescribing all along, because we know that number before was 1% to 2% of people were getting treatment. So I think there is a fundamental workforce need to grow the population of educated and available clinicians who can diagnose, treat, or refer. And if we don't address that, then we're going to always feel like we're lagging behind. And I think time will help, but we absolutely have to figure out some better systems of care that engage primary care providers on the front line, because that's where people are going to present. That's where the bulk of this care should be delivered. We still need to grow the specialist class, I believe, right? We still need obesity trained fellows. We need, people who are getting ABOM certified, American Board of Obesity Medicine certification. But we need to really sort of figure out what's the best system of care for a primary care provider, frontline provider, to be able to engage patients.
Yeah, we got many levels of education, of course, starting with undergraduate education. We're hoping medical students are getting, as well as advanced practice professionals and dietitians and so forth. And of course, I hope podcasts like this are helping with the education, as well as other online CME and meetings and so forth. But staying with the doctor side of it a little bit, I kind of like your thoughts about these medications are being applied for so many other complications and comorbidities, right? Cardiovascular disease and MASLD and sleep apnea, arthritis. Do you envision, either in the short or long term, our specialist colleagues taking up and using these medications, or you think it's going to remain as we call weight loss medications that they refer back to the primary care?
Yeah, I think the strategy that is being pursued to garner additional indications for these medicines has a number of different implications for the specialist class of provider, right? The endocrinologist, cardiologist, gastroenterologist. I do think that it opens the door for the opportunity for them to engage patients and initiate treatment. The one concern I have is that if that provider, that clinician thinks, well, I'm treating MASLD, or I'm treating sleep apnea, or I'm treating heart failure, but I'm not treating obesity. If they're not thinking that, well, the treatment it's indicated, I get the indication by, this complication of obesity, but what we may actually be treating, what we are treating, I would argue, is obesity. And so that may be a different frame of mind and a different complementary set of care tools and co-interventions that might benefit the patient from an obesity perspective, is the way I tend to think about it. And so it just makes me think there's still some questions to be answered. I do think that we'll see greater uptake and that we'll see greater usage of these medications by those specialists. But I also think we need to define what are we treating and how do we make sure that patients are getting the best outcome possible.
Yep. I agree entirely. Let me turn to the other side of the coin, and that is not the clinicians, which we're focusing on now, but the patients, right? Patients we serve and why we go into this profession. It's been very frustrating for us and patients regarding access to these medications. And I wonder if you could speak a little bit about the insurance-related barriers patients are facing regarding these medications. What's the lay of the land, and where do you see this going to, so we could reduce the frustration, I think, that patients often have about these medications?
Yeah, how much time do we have?
Yeah, good
So,
point.
I think the frustration obviously is real. It's been real from day one. We've historically had a challenging road with getting coverage for treatment of obesity medication, even again, earlier generations of meds, because of the bias and stigma and the implications that that has on policy. So we don't generally see consistent coverage. I think these newer meds, especially at a higher price point with greater demand, has put even more pressure on that system. And so we're seeing things like prior authorization requirements that are much more stringent than anything that we've had to do before, deal with before. We're seeing return author or refill authorizations being, a part of that process. There's an expectation that people only take the medication for a short period of time now. That's, I think, even more heightened. And so having to argue for continued therapy, I think, is another part of that frustration. And then I think one of the things that's been most challenging is when people lose coverage when they found something that's been effective, right? So in the state of North Carolina, for example, our state employees' health plan removed coverage after they did an analysis that showed that they were spending more on treatment of obesity than they were on any other disease category. And so that mid-year led to a discontinuation of treatment for people. And we had a lot of patients who felt dismayed, right? Frankly, because they finally found something that was effective for them and now had that removed and didn't have a recourse to be able to get that.
That is very, very frustrating. This, as you know, is a pain point for a lot of clinicians. They often don't even want to get into the whole process of treating obesity because they know they don't have the back office and the bandwidth to handle this. And I wonder if you have any tips that you found in your own practice to try to lessen that difficulty that clinicians have when they're prescribing medications.
Yeah, we try to do a few things that help share the work, if you will. One, we do as much education with patients as we can to really help them understand the process. And we ask them to help us bring information to the table because, as you know, every plan is different. Just because someone has Blue Cross Blue Shield, for example, doesn't mean that, they have the same coverage as the next person who has Blue Cross Blue Shield, right? It may depend on the employer, where they got it off of the exchange, or they Medicare, Medicaid, right? All these nuances. And so we try to help patients understand, here are the things that you need to bring to the table that can help us help you. Look in your plan, ask your plan about coverage options, understand what your benefits look like. Do you have a high deductible plan, right? If you are going to have to come out of pocket for the first 4 months until you reach your deductible, because that's the way your plan is set up, you should be prepared for that. And that's not something we can tell you. You have to understand that yourself. So we try to do as much as we can to activate the patient, empower the patient to know, this is my complicated insurance plan. This is what I have access to. And then we help them navigate in that way. And so that helps, I think, with the patient, one, understanding better the process, and two, we're not doing as much searching, fact finding on the patient's behalf. They're helping us with that.
Yeah, we do this. We do the same thing. Medication prescription is almost a two-part process in my program. One is, let's have the conversation. These are what they are. Here's, the range. Here's a handout. educate yourself the best you can. Here's some resources. Check your insurance. And when you come back, we have a starting point, which ones are available and so on, rather than let's prescribe it and let's play this game where we'll prescribe one, then another one, and nothing's approved, which
We're
is
playing
very
prescriber roulette. Yeah. Yeah.
exactly, exactly. I want to circle back to the earlier question about access and affordability. I actually wanted to ask you this about, we know that whether it's Medicare, Medicaid, other insurance plans, there really is disparity, right? Racial, ethnic, socioeconomic groups. And I think the groups that almost need the treatment the most are unable to get it. And I wonder if you have some thoughts about that, particularly for clinicians who are serving underserved population and so forth, and really can't get their hands on these medications.
Yeah, so this is where I think, that the point you brought up earlier about the other indications that are being pursued for treatment, where I do see some glimmer of potential hope here, right? For example, being able to get semaglutide for our Medicare patients is now an option when they have a history of cardiovascular disease, right? And beforehand, that was not an option. And so while I'm, again, not wildly thrilled about I think there's still some questions to answer in those specific indications and how this deployed. I do think it opens the gate potentially for some of our sickest patients to be able to get access to treatment when there's an indication that is not just obesity, so to speak. I think otherwise, a lot of this comes down to being able to advocate for patients in, however you feel comfortable, should, feel motivated to do, whether it's through participating with a society, a professional society, or doing something locally within your own community, state, or within your health system. I mean, even things like we advocate for, access to these meds for our own employees, for our own teammates, right? It's one of those things where it feels really difficult to practice when you say, look, this is something we believe in, we have the science for, we got a great program here, but we can't treat our own teammates with the treatments that we know are effective. And so we've been successful in advocating for that, and I hope we continue to have access there. But that again is an example of, we got a range of different types of employees who are covering a broad range of pay scales. And even though everyone has insurance, not everyone has true access because of copays or deductibles. So I think there are opportunities for us to advocate in lots of different spaces in lots of different ways.
Yeah, good. If we go one step further, and everything you said, I agree with completely, which is the here and now. But as we look forward to changes that may occur, we know some of these medications are going generic, so that's going to be more competition, um, bringing prices down and so forth. But what other advocacy or legislative approaches are going on in the field that may help make these drugs more affordable and accessible and available for our patients?
Yeah, so one longstanding initiative has been the Treat and Reduce Obesity Act, as you know, the TROA bill, as it's called. And the intent here is to be able to open up access to these medications by really sort of getting at the core language that has historically been used to disallow coverage of these medications for Medicare. And so the idea is, if we can get Medicare to agree to cover these meds and adopt a new perspective on obesity treatment, not weight loss, right? So this is not weight loss, which is not a disease. It's cosmetic, if you will, right? That's the framing, versus saying, well, this is obesity and it's a disease and it requires therapeutic, effective therapy. Then being able to adopt that framework and that language opens up the door for Medicare to then say, okay, yes, we can cover therapies that have the evidence of being effective for the treatment of obesity. So that, as I said, has been a longstanding effort, probably 10 to 12 years now of effort going into trying to get legislation passed. I think there's signs that, yes, there may be progress on the horizon. I've heard that there might be a pilot that CMS will do to look at, the potential, coverage. I've also heard that there've been concessions or, sort of proposed plans that might look at, well, if you started on a treatment, let's say you were employed and you retired and you were on treatment, you might get to continue that treatment as you transition into Medicare. I mean, I've had several patients who've had to stop because of something like that, right? They lost coverage as a result of retirement. So I think there are a couple of different things that are happening. And then lastly, I'll say at the state level, we've seen a lot of local activity that's been successful in terms of getting Medicaid coverage, right? So Medicaid is really dictated at the state level, and seeing that, some local groups have been successful in getting Medicaid coverage for obesity treatment. The key is being able to sustain that and make it such that it feels viable for the Medicaid plan over a long period of time. Again, given the cost, I think as you talked about, right, is as the cost comes down, as there's more competition, other meds come into the market, generics, et cetera, we could start to see a different sort of set of utilization and opportunity for coverage for a broader group of people.
Yeah, it only hope. Hope is on the way. I anticipate. I want to turn direction a little bit to a patient care dilemma that we all face as clinicians, and that is persistence of use. Many real-world experience studies show that folks are off these medications, about 50% in some studies in a year, and by 2 years, 70% or so. And I'm not sure it's that much different than other medications that we use, but we know obesity is a chronic relapsing, long-term disease. What are your thoughts there? Real-world data doesn't tell you why, right? It just gives you, are you on it or are you not on it? So have any thoughts about why the persistence is dropping off when people see their weight coming off, or at least the majority of them are?
Yeah. I think there are a few systems related issues here, some of which we've already sort of touched on or alluded to. But if we think about the system and how it's set up in terms of how people are getting access to treatment, the vast minority of people are getting treatment from someone who is trained in obesity medicine and knows how to use the broad array of therapies in what I would say is a, sort of most effective way, right? So that being the case, I think there's a large group of individuals who may be getting medication therapy from someone who isn't as well trained in how to manage treatment, how to mitigate side effects, how to adjust therapy for the given patient. And so some patients may end up discontinuing treatment because I think their treatment just may not be optimized, and they feel like it's either ineffective or too difficult in terms of being tolerant to that therapy. So I think there's an issue there, which is, again, about education, access to trained individuals and clinicians who can, really sort of give the patient the best chance to be successful. I think another part of it is related to the perspective that a lot of patients have, which is, okay, I've got it fixed and I can take it from here, right? So I have a lot of patients who now the conversation, as you talked about, has changed from like I'd have to introduce medication and talk to them about why it's effective and, the potential benefit it might have in their treatment plan to, right, they come in and they're saying, I'm interested in medication, right? So I don't have to have that conversation. But the conversation I am having now is, oh, you mean I need to take this long term? Oh, I didn't quite understand that, right? So there's still a perspective, I think, in a large percentage of our patients who sort of see this as, well, I'm going to use this as a booster, right? I hear that word a lot, right? It's a booster or it's a jump start. And once I can get over that initial hump, because, everybody feels like pretty confident that they can do something probably for a couple of weeks. It's that next 3 to 4 weeks after that they call the hump, right? If you can get over that and you can keep your momentum going, and like, oh, I've got it. I got it figured out. But I use the analogy of like it's the person with depression who's been on an antidepressant for several months and now finding that they're not depressed anymore, right? The idea, isn't that, okay, I've beat my depression and I'm done with this because I feel good today, right? Well, I feel good today because I'm taking my antidepressant. So I think that is another part of why we're seeing a high discontinuation rate. And then I think the last thing is what we just talked about, which is around access, the changing, environment around insurance coverage and cost and what the patient is responsible for. And I think some patients honestly go into it knowing that I can't sustain this long term. I'm willing to pay out of pocket, but I know that I'm not going to be able to do this forever, but I'm going to do this in the hopes that it's good enough to help me again sustain my weight loss longer term, because I know I can't afford it long term.
Yeah, great points. When it comes to the educated clinician, which we were talking about regarding the indications and the use and the benefits, of improved health, this brings up probably one of the most important ones, and that is how to manage the patient on this medication, mitigate the side effects so that you could increase adherence and persistence. Because without that last element, patients are going to stop using it. They're going to have one bout of either vomiting, diarrhea, or just terrible reflux, or go to the emergency room and they're done. Right. So without those expectations and that educated monitoring and how to mitigate those things, it's going to be very, very difficult to do that. Jamie, as we circle towards the end here, are there any other dilemmas regarding the use of these medications we didn't talk about, or are there other areas you really want to reinforce for the clinician who's listening to this podcast?
Well, I think I'll go back and reinforce the idea that as people are coming to the conversation now because of these newer medications, and previously, let's call them treatment naive, right? They maybe have done something, sort of on their own. They've done a lifestyle only intervention, never had any type of pharmacotherapy or surgical treatment. And they find that, or the clinician finds that they don't have access to the most highly effective therapies, these newer treatments. I know that can be disappointing, but I would encourage people to also sort of continue the conversation and say, there is still hope. There are still options. And these are what those options look like. And those can be accessible because they are generic or because you do have coverage for surgery, right? So I really want people to think beyond just, oh, well, I don't have access to these two medications, and so that means I don't have treatment options, or I'm not going to be successful, right? We've been helping people successfully treat obesity for a long time, albeit the tools are not as great as the tools that we have now in the toolbox, but there's variability in that treatment response, as we know, right? There are lots of people who don't respond to one treatment, but will respond to the other, and there's no prediction or correlation between those two. So I would encourage people who are listening to this podcast to be thoughtful and mindful of the fact that someone might really be, set on, I'm going to have the latest, newest injectable GLP-1 based treatment, but it may not be available to them, and you could still get them effective treatment by exploring other options.
Yeah, and both of us, of course, want to reinforce, I don't want to forget this, the importance of the foundation of lifestyle management, right? We're focusing
absolutely.
We're focusing on medications,
absolutely.
but both of us really is really to talk about all the diet, physical activity, sleep hygiene, stress, social connection.
Behavioral health. Yeah, absolutely.
Exactly. I want to make sure we got that in there. I don't want to get a message saying, well, you guys didn't even talk about lifestyle medicine. Absolutely foundational. It's just not the focus of this podcast. Jamie, thank you so much for this excellent discussion, and thank you for listening. Please remember to take the post-test and evaluation to receive CME credit and to tune in for additional episodes within the podcast series.
Thank you for listening to MedEd Talks Primary Care. Just a friendly reminder, CME credit can be claimed through mededtalks.com. For other episodes in this series, search for Expert Weigh-In Podcast Series.